field of torics. I'm Dr. SWATI AGARWAL from Kolkata, and I would be speaking on optimizing outcomes. Well, so I would say optimize the chakra of actions, pre-operative, intraoperative, post-operative. Accuracy with precision at all levels should be targeted. Pre-operative evaluation is the key. Evaluate for irregular astigmatism, dry eye, calculate the keratometry readings, need to put all the readings in Barrett's toric calculator, we would see. So what about the dry eye assessment? Well, consistency is the key. Multiple readings needs to be taken. Discontinue contact lens wear. If there is an inconsistency in the readings, treat dry eye before remeasurements. So the picture on the right shows for the right eye, no drop was instilled and the cylinder powers are correlating. But for the left eye, since a drop was instilled, the powers are not correlating. Now, put all your data, all your measurements on the Barrett's toric calculator, because on the left-hand picture shows 1.5 of SIL, and on the Barrett's it shows 2.16 because it's also incorporating the PCA. Now, this study shows that integrated K method is the best way of calculating your K reading because this is more accurate and precise than other methods and should be taken from multiple devices. Coming to pre-operative marking techniques, could be slit lamp, bubble marking, freehand which can be confirmed with the smartphone app, and image-guided systems like with the visual measurement unit or the Callisto. So ink marking in the theater, this has to be done on the dry eye, dry cornea, and the Mendes ring in the left hand and the axis marker in the right hand, and just mark once. There should not be any double marks. With the digital overlay, it also shows us the capsular excess margin and the various registration has to be done, and the digital overlay is there, which is a live image. And thereafter, the implantation can be done as per the axis. So digital image guidance delivers better outcomes than slit lamp assisted and other conventional marking ink techniques in terms of astigmatism. We've done a study of smartphone assisted versus the image guided, and we found equal results. And the femtosecond laser marking can also be done. Over here we can see that after the Mendes ring, we're just correlating with after application of the Mendes ring and the axis marker. Just below the axis mark, we can see a faint glow. So that is with the femtosecond laser, it has been done. And we found that this also correlates well. So intraoperative wavefront aberrometry can be done, but this also estimates the ELP. So what are the pearls to minimize IOL rotation? Well, optimum rexis size should be targeted and a concentric overlap with the optic of the IOL. Wash behind the IOL, and at the last tap the IOL so that it stays in contact with the PC. Do not underfill or overfill the eye. Do not polish the anterior chamber because that helps in the tachiness. Give a CTR if the patient is a myope. Minimize activity of the patient in the post-operative period because of maximum rotation happens in the first hour and the first 24 hours. Correct dry eye atopy as dropping may lead to rotation from the poor quality of vision. So now whatever the patient asks for, do oblige, try to oblige, because if the patient is asking for flax with EDOF toric, do give, there was a claustrophobic patient which had to be taken under GA, we gave torics for the same patient. Now 82-year-old lady with diabetic macular edema, well that can be taken up for torics, a patient of IFS or intravitreal injections. Well, what I meant by showing these cases, we can explore possibilities, and my take-home message would be, believe in the available instrument, work on accuracy, technologies for mankind, and there should be a broad inclusion criteria for torics. Thank you so much.
Excellent presentations. I think there's so much which has been added by both the speakers. In our practice also, what we are doing is we are punching in all patients on a toric IOL calculator. And even with 0.24, more so if the patient happens to be against the rule, it comes. So I fully believe that torics have made a difference, and we should not shy. There should not be any limit, the lower limit or the upper limit. Anything which the toric Barrett toric calculator picks up, a toric IOL should be implanted, definitely by all means. And in all these patients, we should not rush to decide about the toric IOLs. We have to give the tear film and everything the time to stabilize, and then only we should go ahead with the toric implantation. Markerless has added, makes life so much easier. makes life faster, and it basically makes the transition very smooth. If 30% of your patients or 35% of your patients have a toric IOL, which comes with the calculations, you do not feel any hassle about it. Dr. Sujata?
I just would like to emphasize, like once you see the patient has a small cylinder, you have to do a topography, you have to do an eye trace. So you make sure that whatever your readings you're getting is perfectly all right, and also look at the ocular surface like Dr. Rohit said. So these are some of the very important things that we should do pre-operatively to make sure that you're catching the cylinder. And for me, the cutoff is 0.75. For not, I don't go down to 0.25. Like Sir said, I do about 0.75. So anything 0.75 and above, I would definitely go for a toric. And like what she mentioned, would like to make the patient lie down at least for a couple of hours in the hospital.
Very important.
Because nowadays, everybody wants to go out.
Yeah.
No patch, nothing. So we just want to go out. But we have to tell them to lie down for 2 hours and then go home also and take rest only for the first 24 hours, and hopefully it should not rotate. And most of these lenses which we are using now, the rotation rate is very, very less, but still we have to keep it in the back of our minds, because ultimately the patient is paid for a premium lens, and then 1 week post-op he comes with a cylinder, he's going to be very unhappy.
I think in counseling, we should give a passing reference that we might have to, rotate. Yeah, I think that should be an obligatory and mandatory thing in the counseling. Dr. Anurag, would you like to add something?
So first of all, beg an apology. I don't have enough beds in the hospital to ask my patients to lie down for 2 hours, considering the number of surgeries that I handle every day. There's nothing to boast in this. I'm just saying that I'm short of space in the hospital. And personally speaking, I have never felt the necessity of that. Talking about the brand of IOLs, as ma'am's rightly mentioned, that we use nowadays, if we are not leaving any lubricating material inside the bag, like the visco, then perhaps and we have ensured that it's a perfect shrink wrap. If the fit is proper, the alignment is proper, and the brand of the IOL is something we have trusted for years, there is perhaps no need for, because activity of the body does not necessarily extrapolate to the eye, and it doesn't cause rotation. That's the only thing that I would do differently.
I think they have done a study for that.
I know.
Yeah.
The rotation, so the study says out of the rotations that take place, maximum occurs in the first hour.
Yeah.
That's what the study says. The study does not say, if the rotation itself is likely to occur in 0.2% of the cases, then, the numbers are too minimal for us to, how would I put it? Bind all the patients to the hospital's boundaries for a 2 hours period. In my practice, it is not practical, and honestly, I have not felt the necessity. We might have different.
We never used to do it, but now I don't want to mention the name of the lens, but when we're using IQ lenses, we never used to do it. But now, off late, because we've switched over to Technis platform, we ask them to lie down, because the IQ basically has some sort of a bioadherence.
Yeah.
So the capsule adheres to it very quickly. So we didn't see much rotation. Even now, these lenses, we don't see any rotation, but because of the study, we started making the patient lie down.
You had mentioned about putting CTR in myopes. So what is your cutoff, wherein you put a CTR, and what are your indications for putting CTR in myopes, for that matter?
Yes, sir. So I had done an 8 diopter and a 11 diopter. Those cases I used a CTR.
Okay.
It's actually
I
a
did not
double-edged
use any
sword.
cutoff.
It's not something that is always productive for you. It can be counterproductive as well, because
Yeah.
it prevents the ring of sommering formation, because it stretches the equator. So you have to take a call.
Yeah.
I think if the bag's doing fine in terms of its steadiness, then perhaps we don't need the services of a CTR. But if the bag's wobbly, when you find it out on the table, so all myopics as a rule, or even higher myopics as a rule, might not need it. But sometimes if the bag's not behaving the way you like it to, then maybe CTR can be
So
put.
when the bag was too big, so theoretically we've learned to give a CTR, so I gave a CTR. Haven't done a study whether that would help or not.
Great. So you would like
Just one last question. This is for the learning of many people who do not have pentacam handy. So how much of cylinder should you really consider when you are doing with a system which is not like IOL master, you're doing a contact method. So how much of cylinder will be forgivable if you don't have a pentacam always?
We are
So
not.
0.75
No, we are
and
not
all.
using pentacam.
Okay, so you go,
So
no,
all,
but
all that you need to do is you put it on the Barrett toric
Yes.
calculator, which is
Yes.
available everywhere.
online, yes.
And your persons have to be ready for it.
Yes.
So,
This
you
is
know,
the message basically, sir.
they
That is
don't-
what.
Your assistants will try to dodge you by not doing it all, because this is a fitrat in, at least in North India. They don't, you have to reinforce it again and again. So, but toric calculator is freely available on, so that.
Yes,
that
so
should-
whatever method we are using for IOL calculation, it is always better to subject that to a toric calculator and find out and
yeah.
do a toric.
Yeah.
Thank you so much.